Zepbound, Mounjaro, and Tirzepatide protocol for effective medical weight loss. Tirzepatide, also known as Mounjaro and Zepbound, is a glucose-dependent insulinotropic polypeptide receptor and glucagon-like peptide 1 receptor agonist. Tirzepatide is FDA approved as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes and for adults with obesity. In this course, we'll provide a comprehensive overview of tirzepatide as a medical weight loss treatment option. This is an overview of tirzepatide as a medical weight loss treatment option to equip you with the knowledge and tools needed to successfully incorporate tirzepatide into your clinical practice for the management of obesity. Understanding glucagon and GLP-1. Glucagon and glucagon-like peptide 1, GLP-1, are two peptide hormones that regulate glucose homeostasis. Glucagon, a 29 amino acid hormone, is secreted by the alpha cell of the pancreatic islets in response to low blood glucose levels. It raises blood glucose levels by stimulating glycogenolysis and gluconeogenesis in the liver. Also, glucagon promotes lipolysis in adipose tissue, providing free fatty acids as an alternative energy source during periods of low glucose availability. Since insulin promotes glucose uptake and storage, glucagon is a counter-regulatory hormone. GLP-1, a 30 amino acid hormone, is secreted by the L cells of the gastrointestinal tract in response to food intake. GLP-1 helps in glucose homeostasis by enhancing glucose-dependent insulin secretion from the pancreatic beta cells, inhibiting glucagon secretion and delaying gastric emptying. These actions result in reduced postprandial glycemia and improved overall glycemic control. GLP-1 also has central effects on regulation of appetite and body weight, as it acts on the hypothalamus to promote satiety and reduce food intake. Tirzepatide is a glucose-dependent insulinotropic polypeptide receptor and glucagon-like peptide 1 receptor agonist, developed initially as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. The mechanism of action of tirzepatide mimics the effects of the native hormone GLP-1, which is released in response to food intake. By binding to the GLP-1 receptors in the brain, tirzepatide reduces appetite and food intake. Additionally, tirzepatide slows gastric emptying and improves insulin secretion, which improves glycemic control. It has an extended half-life, about 1 week, due to its structural modifications, allowing for once-weekly subcutaneous administration. The mechanism of action of tirzepatide includes the following. 1. Enhanced glucose-dependent insulin secretion. Glucose-dependent stimulated insulin release from pancreatic beta cells, which improves glycemic control. 2. Suppress glucagon secretion. Inhibits glucagon release from pancreatic alpha cells, which reduces hepatic glucose production, which improves glycemic control. 3. Delay gastric emptying. Slows gastric emptying, which helps in reduce postprandial glucose excursion, which is the change in glucose concentration from before to after a meal, and promotes satiety. 4. Reduce appetite and caloric intake. It acts on the central nervous systems to regulate appetite. Tirzepatide was being studied in comprehensive clinical trials known as SURPASS. Here's a summary of the key trials. SURPASS-1 was a 40-week randomized double-blind placebo-controlled phase 3 trial involving 478 patients with type 2 diabetes, inadequately controlled with diet and exercise alone. Patients were randomized to receive either tirzepatide, 5 milligrams, 10 milligrams, or 15 milligrams once weekly, or placebo. The trial demonstrated that tirzepatide resulted in significant improvement in hemoglobin A1C and body weight compared to placebo. SURPASS-3 was a 52-week randomized open-label parallel group phase 3 trial comparing the efficacy and safety of tirzepatide in 1,879 patients with type 2 diabetes inadequately controlled on metformin. The trial found that tirzepatide was superior in reducing hemoglobin A1C and body weight. Both trials demonstrated the efficacy of tirzepatide in improving glycemic control and promoting weight loss in patients with type 2 diabetes. The FDA approval for Zepbound was based on the outcomes from phase 3 of the SURMOUNT-1 and SURMOUNT-2 studies. Within the scope of SURMOUNT-1, a research involving 2,539 adults affected by obesity or excessive weight with associated health conditions, excluding diabetes, it was observed that those administered Zepbound alongside diet and exercise witnessed significant weight reduction when compared to a placebo group over a period of 72 weeks. In both studies, the primary measures of effectiveness were the average percentage change in body weight and the proportion of participants achieving a reduction of at least 5% in body weight from the baseline to week 72. After 72 weeks of Zepbound treatment, there was a statistically significant decrease in body weight compared to the placebo. Additionally, a higher proportion of patients treated with Zepbound doses of 5 milligrams, 10 milligrams, and 15 milligrams achieved a minimum of 5% weight loss compared to those on placebo. Specifically, in patients treated with 10 milligrams and 15 milligrams of Zepbound, a larger proportion attained weight loss of at least 10%, 15%, and 20% relative to placebo. Contraindications include personal or family history of medullary thyroid carcinoma or in patients with multiple endocrine neoplasia syndrome type 2. Also, known serious hypersensitivity to tirzepatide. Limitation of use. It is advised against using Zepbound in conjunction with other products containing tirzepatide or any GLP-1 receptor agonist. The safety and effectiveness of using Zepbound together with other weight management products have yet to be determined. There have been no studies conducted on Zepbound in individuals who have previously experienced pancreatitis. Warnings and precautions. Severe gastrointestinal disorders. Administration is linked to gastrointestinal side effects, occasionally severe. It has not been evaluated in individuals with severe gastrointestinal disorders, and its use is not advised for these patients. Acute renal failure. In case of side effects leading to potential volume depletion, renal function should be monitored. Acute cholecystitis. Reported in clinical studies, if cholecystitis is under consideration, appropriate gallbladder examination and clinical monitoring are recommended. Acute pancreatitis. Occurrences reported in clinical trials. Stop use immediately if pancreatitis is suspected, and do not recommence if pancreatitis is confirmed. Allergic reactions. Severe allergic reactions, such as anaphylaxis and angioedema, have been observed post-marketing with tirzepatide. Advise patients to seek medical help immediately if suspected and cease Zepbound. Low blood sugar. When used with insulin or drugs that stimulate insulin production, the risk of low blood sugar, including severe cases, may increase. It may be necessary to lower the dosage of insulin or these drugs.
Educate all patients about the risk of low blood sugar and its symptoms. Diabetic eye disease complication and type 2 diabetes. Monitor patients with a history of diabetic retinopathy or worsening conditions. Suicidal thoughts and actions. Be vigilant for signs of depression or suicidal thoughts. Discontinue Zepbound if these symptoms appear. This table shows common adverse reactions associated with the use of Zepbound in the placebo-controlled trials for chronic weight management. Please note that nausea and diarrhea can occur in 20 to 25% of patients. Other symptoms such as vomiting, constipation, abdominal pain can occur in up to 10% of your patients.
Drug interaction. Tirzepatide delays gastric emptying and has potential to impact absorption of other oral medications. Tirzepatide has not been tested on pregnant women, and based on animal studies, it may cause fetal harm. It is advised that women who are using oral contraceptives to switch to a non-oral contraceptive method or add a barrier method prior to initiating tirzepatide and 4 weeks after dosage escalation. Baseline measurement and laboratory test. Before initiating tirzepatide, the following baseline measurement and laboratory tests should be considered. BMI and body weight, blood pressure, heart rate should be measured in all patients. Laboratory tests such as glucose lipid profiles, renal functions, thyroid function, and liver function should be performed in all patients. The recommended starting dose is 2.5 milligrams injected subcutaneously once a week. After 4 weeks, you can increase to 5 milligrams subcutaneous once weekly. Then you increase the dose in 2.5 milligrams increments after at least 4 weeks of the current dosage use. The maximum dosage is 15 milligrams subcutaneous once weekly. You are to administer once weekly at any time of the day with or without meals, and you inject subcutaneously in the abdomen, thigh, or the upper arm, rotating the injection site with each dose. If a dose is missed, it should be administered as soon as possible within 4 days after the missed dose. If more than 4 days have passed, the missed dose should be skipped and the next dose should be administered on the regularly scheduled day. The American Association of Clinical Endocrinologists and the American College of Endocrinology guidelines recommend that patients receiving treatments for obesity be evaluated every 4 to 12 weeks. During the first few months of the treatment, when dosing titration occurs, it is essential to maintain close monitoring for side effects. Once the patient has reached the maintenance dose, follow-up appointments can be scheduled according to the needs of the patient. More frequent follow-ups may be required if the patient is experiencing side effects. Compounding pharmacies and tirzepatide. What is a compounding pharmacy? Compounding pharmacies create customized medications by altering, combining, or mixing active pharmaceutical ingredients to cater to specific patient needs, such as creating formulations that are free of allergens, altering dosage forms, or combining multiple medication into a single dose. What is off-label use of medications? Off-label use refers to the prescription of an FDA-approved medication for a purpose, dosage, or population that is not explicitly approved by the FDA. Physicians prescribe medications off-label based on their professional judgment, as long as they believe it is in the best interest of the patient. FDA's role in compounding and off-label use. Compounding pharmacies are subject to FDA regulations to ensure they meet specific standards for safety and efficacy. However, the FDA does not regulate the practice of medicine and do not oversee the off-label use of medications. The decision to prescribe a medicine off-label is at the physician's discretion based on medical judgment, scientific evidence, and the patient's best interest. Balancing benefits and risks. There are potential risks associated with these compounding of medication, such as varying quality, potency, and purity of compounded medications, or lack of substantial evidence supporting off-label use. Physicians should carefully weigh the benefits and the risk of using compounded medication while adhering to regulatory guidelines and professional standards. The safety and efficacy of compounded tirzepatide does not go through a rigorous oversight like the FDA-approved Mounjaro formulation. Compounded tirzepatide vary in quality, potency, and purity, which may lead to suboptimal treatment outcomes or adverse events. Finally, many of the compound pharmacies are not being transparent about how they're sourcing compounded tirzepatide. Eli Lilly, the manufacturer of Mounjaro, has said that it does not provide tirzepatide to these compounded pharmacies. Industry insiders speculate that compound pharmacists could be giving patients tirzepatide acetate, a cheaper modified version that is intended for research use only, not for humans, veterinary, or therapeutic uses. Compounding pharmacies could also be purchasing a high dose of tirzepatide from the wholesalers and then separating it into smaller doses or mixing it with other drug ingredients. Considering the potential risk associated with compounded tirzepatide, physicians should prioritize prescribing FDA-approved tirzepatide. Adhering to FDA guidelines and best practices, physicians can optimize care while minimizing potential risk to patients and legal implications related to compounded tirzepatide. Pricing. Currently, the list price of Mounjaro is $1,023.04 per fill, but the amount that the patient pays largely depends on the prescription drug plan. Prescription drug prices are confusing. Different people will pay different prices for the same drug depending on the insurance situation and the state that they are in. Patients can also apply for the Mounjaro Savings Card program. If you are eligible for the Mounjaro Savings Card, you may pay as little as $25 for a 1-month or a 3-month prescription for Mounjaro. This depends on whether you are eligible for the Mounjaro Savings Card. Patient must go to the website to apply and answer the questions to confirm eligibility. Tirzepatide in clinical practice. Currently, there are 2 types of medical weight loss treatment practices. First type uses the on-label FDA indication for Mounjaro. The problem with this is that if your patient does not have type 2 diabetes, then it is unlikely that the insurance company will cover your off-label indication. You may even still have problems with getting authorization with your insurance company. If that's the case, please contact the local specialty pharmacy, which may help you get prior authorization approval. The coverage amount varies from state to state and from insurance companies to insurance companies. It varies from 50% to 80% coverage. The second type uses a non-FDA approved tirzepatide that has been compounded with another drug or supplement from a compound pharmacy. FAQ about compounded tirzepatide. Where do I buy compounded tirzepatide? If you would like to learn the complete tirzepatide implementation protocol, or you want to get a certificate for medical weight loss training, then please go to medicalweightlosstraining.com and sign up for your online course. This is Dr. J. Park for medicalweightlosstraining.com. Thank you very much for watching and listening.